morning, folks. You're all very welcome. I'm Dr. Colin Kenny. I'm joined, very grateful to be joined by Dr. Diarmuid Quinlan this morning, who is a GP in Cork and also a tutor, who's also the lead in diabetes for the RCGP Ireland. And we will be joined by Dr. Stephen Lawrence, who is in charge of the Warwick end of the diploma, and he will be helping with the Q&A. Diarmuid's going to make a short presentation after mine. So no one would have believed at the start of 2020 that this small strands of RNA protein would have such a big impact on our lives going forward. I've chosen this quotation from Tedros, the director of the WHO, a beleaguered individual at times, but he's very wise in what he says, that this is the time for facts, not fear. This is the time for science, not rumors. This is the time for solidarity, not stigma. We are all in this together, and we can only stop it together. And I think these are very inspiring words about a pretty horrible illness. And in that spirit, I'm going to go forward with my presentation this morning and try and stick to facts about this, this virus. Now, this looks like a very heavily pixelated picture, but in fact, it's a composite done by an artist from about 1,500 photographs sent to him of healthcare professionals. And I put this up to pay testament to the over 200 healthcare professionals who have died in the United Kingdom from COVID-19. And for that reason, I've called this presentation COVID-19 and Diabetes, a Catalyst for Change. And I'm going to take the theme of a catalyst going forward. This is who I am, and I want to acknowledge colleagues from PCDS, Pam Brown, Jane Diggle, and David Miller-Jones, who have helped me with slides for this presentation. So my presentation is in 3 parts. I'm going to start by looking at some facts about COVID, how you test for it, some observation data, and then reflect on people living with obesity. Then move on to managing drug therapy and the importance of remote working. Now, I think it's important to get a sense of perspective on the coronavirus. This is from Diabetes UK, the leading charity in the United Kingdom. They were very keen to reassure people living with diabetes that, of course, the risk is low of death. And as we manage to get it under control, that risk will lower. And of course, they represent children and young people with type 1, and their risk is low. And under the age of 40, the risk is very low, mortality risk. And I want to just use that perspective because I am going to come on to some quite disturbing data shortly. So it is a severe acute respiratory syndrome, coronavirus, or a SARS virus that gives COVID-19. I'm emphasizing that because quite a lot of governments have planned their pandemic planning around a flu virus, whereas we now know that this is a much more serious illness than a flu virus. The incubation period is about 5.1 days. You're symptomatic in 12 hours after the onset of symptoms, and then you remain infectious for 4.7 days. And we all know that the symptoms are fever, principally cough, shortness of breath, and breathing difficulties. And those are not exactly the same, I'd have to say. Now, again, Tedros was very famous for this test remark. Remember, there are 2 tests. The antigen test that asks, have I got COVID now? Remember, this is nasal and throat swabs, rather unpleasant to get, but you should get the answer in hours. And then an antibody test that answers the question, have I had COVID? And this you get within 15 or 20 minutes. But an unreliable test is worse than no test. And this I've taken from the BMJ last week when it comes to interpretation of results. There's a couple of things that are important. The accuracy of the test, and then the probability or estimated risk of the disease before testing. Now, this may seem a little bit abstract, but remember, the same applies to A1C when you're going to diagnose diabetes. And you'll all be hearing about this in Module 1. So some of you live in parts of the world where the pre-test probability is very high, such as Kuwait in the Middle East. And that does have an effect on the diagnosis. A positive RT-PCR test, that's the acute test for COVID-19, has more weight than a negative test because of the test's high specificity, that's for ruling things in, but moderate sensitivity for ruling things out. So therefore, a single negative COVID test should not be taken to rule out patients with strongly suggestive symptoms. And this is an important thing. Clinicians should share information with patients about the accuracy of COVID-19 tests and deal with their expectations. So who's at increased risk of a positive SARS test in the general population? Again, from the Lancet last week, what increases your pre-test probability is age, male sex, population density, if you live in a more deprived area, if you have Black and minority ethnicity, and chronic kidney disease and obesity. Now again, in Module 1, we teach you about the hierarchy of evidence and that importance. So just to say, most of the studies I'm going to show have low quality of evidence in as much as they're case reports and cross-sectional studies. Of course, we haven't got to randomized controlled trials yet. And this morning, I'm not going to speak about some of the purported drug treatments for COVID-19 because none of them have any mortality benefit. Some do harm, and none have been subjected to really good randomized controlled trials yet. So just remember what I'm showing is case reports and cross-sectional studies. So let's start with, again, 2 weeks ago from Diabetes Care, what they discovered from mainly Chinese data. Sadly, for people living with diabetes, the overall mortality was 28% after hospitalization, which is very striking. And the people who were most affected were older age, early evidence of organ failure, a high C-reactive protein on emission, and low oxygen saturation on emission. And then this very striking near linear relationship between higher BMI and a severe critical illness was demonstrated in the whole Chinese cohort. Moving on then to English and other data. If you were using insulin before you got COVID-19, you had a worse outcome. If you had diabetes and got to an intensive care unit, you had a worse outcome. And then looking at English data then, if you had poor renal function and BMI, high BMI, you had a high mortality rate. And then this striking English evidence that if you belong to the Black, Asian, and minority ethnic community, then you also had higher mortality. As sadly, we found out from many of the healthcare workers in the UK who died also were from the BME group. And again, English data has shown that obesity is a major risk factor for diabetes, but it's also an independent risk factor for severe illness in COVID-19. So it raises the question, why are people living with obesity so adversely affected? Well, first of all, they have a higher metabolic rate, they need more oxygen and can't get rid of carbon dioxide as easily. And this is, of course, a respiratory illness they're having. Obesity and overweight are underlying factors for CVD, type 2 diabetes, and hypertension. There's this so-called cytokine storm going on, which seems to amplify the attack of COVID-19. Once again, it acts like a catalyst, as I've mentioned. And then almost 50% of people in hospital with COVID-19, 75% were admitted to ICU are overweight or obese. This makes them hard to ventilate and also hard to prone, which they've been doing with COVID patients, as you know, turning them on their tummies. And then once you get your BMI over 40, it's the second highest risk factor for death after old age. So now we're moving on to New York data, not quite as striking as the Chinese data, but still, if you had diabetes, you were more likely to die and more likely to go into hospice care. Again, now this is a separate Chinese study by Zhu, just to point out well-controlled versus poorly controlled people living with diabetes. You can see there very striking difference between the poorly controlled and the well-controlled people living with diabetes. Should we stop ACE inhibitors? This came out early on because the COVID-19 appears to get into the body through an ACE mechanism, the endogenous membrane protein that enables COVID-19 infection. And this is what you're asked, but authorities are saying quite clearly not to stop antihypertensives, both ACE inhibitors and all antihypertensives. So that's a rumor and a myth, and you shouldn't do that. So where are we with COVID and evidence and guidance? Let's just summarize. You have, as somebody living with diabetes, you have the same risk of COVID-19, but you're more at risk of getting it, but you're more at risk of complications and death. Type 1 and 2 diabetes have the same risk, but if you're a poorly controlled type 1, sick day rules can be more challenging. People living with diabetes can suddenly go off, and they may be okay earlier and then suddenly deteriorate. Hospital admissions are seeing mixed DKA and hyperosmolar states. They certainly should be admitted. Groups most at risk are the elderly, existing CVD, diabetes and respiratory disease. If you're talking to patients, encourage them to stock up on medication and food. They should understand sick day guidance and fluids, when to continue insulin, when to stop and restart meds, and then educate them when to self-isolate and when to seek help and how to do it. So let's look now at high-risk groups. Let's look specifically at diabetes medication, and then let's look at emotional well-being. Well, any illness by itself has an effect on glucose metabolism because of the cortisol and adrenaline hormones have tend the body to oppose the action of insulin and promote more glucose. When you're ill, you don't feel like eating so much, you don't take as much carb, and this can give you hypoglycemia. But do remember, the hazard is that with DKA, you want to give a lot of fluid, but because this is a pulmonary illness, fluid accumulating in the lungs make it very difficult to treat lung disease. And that is the slight paradox about rehydrating people. So definitely dehydration is a red flag, and I'll come back to red flags shortly. Now, this is the vulnerable and the shielding group. So my daughter, who's a type 1, is in the vulnerable group with diabetes, but she's not in the shielding group. But if she also was living with, say, cystic fibrosis or asthma, she would move to the shielding group. And that is a big impact about what people are allowed to do. So this is, this time the University of Oxford is saying that people, what I'm saying is that people get more severe infection, although as yet the data is not completely clear. We need more data to really get an idea of what COVID-19 does with diabetes. Consensus document from the Lancet this month is telling you what to do about outpatient care, inpatient care, but also what sort of levels to set your blood sugars at. So plasma glucose should be between 4 and 8 ideally. HbA1c, your target should be 7%. And if, like Kenny, you're doing continuous glucose measurements, then your time in range should be more than 70% of the time, and you should avoid hypoglycemia. What about specific diabetes medication? Watch for reduced appetite. Something like sulfonylureas can put your sugars down. You could stop oral hypoglycemics that can cause, and this can cause raised blood sugar. You will need to do frequent blood glucose monitoring. rather like you do in Ramadan. And there's no if you don't have access to that, then the patient really needs to recognize the symptoms of high blood glucose, thirst, and passing more urine than usual. What about medication specifically? Metformin you should continue with, but it has more risk of an acidosis. Sulfonylureas, if you're not eating and drinking, you're certainly at risk of hypoglycemia. GLP-1s can be continued, but do watch for dehydration. And then you probably know about SGLT2s. They are exacerbated by dehydration, and you're more likely to get ketoacidosis and euglycemic acidosis with SGLT2s. DPP-4s probably are low, not terribly effective drug, are very well tolerated and probably quite safe. Insulin is an important drug. I mentioned earlier that it was a marker for poor control, but if you're on insulin, then you certainly need to use it optimally by regular self-monitoring every 2 to 4 hours, ideally glucose monitoring, and then carefully adjust according to your blood sugars. And of course, we'll be telling you this in module 2, how to do all this. Just want to touch a little bit on depression. It's a common comorbidity of diabetes. About 1 in 3 people with diabetes will suffer from a major depressive order. We do cover all this in module 6. But then there's also a bidirectional relationship with diabetes. You probably are aware of that for people living with schizophrenia, but it's also the case for depression, and it's thought to be maybe a causal role in diabetes. I flagged this up also because do think about your colleagues that are working hard as well, and I think there will be quite a lot of post-traumatic stress disorder following this condition. Now I'm going to finish now with remote working, and Diarmuid Quinlan is going to help me with this, but just to say, we've all learned new ways of working in the UK and Ireland. Remote working has become much more important. What sort of telephone advice would you give to somebody with suspected COVID-19? Well, it's common to feel anxious and worried. There's so much in the news about it. Following government advice is important. Hand washing, of course. Most people can be managed at home. Hope they understand about what isolation means. Ensure they follow general sick day guidance for people with diabetes, and the majority of individuals, as DUK said, will recover from COVID-19. It's the individuals that get into hospital that do particularly badly. What sort of red flags should you be considering? Well, if you're speaking to patients on the phone, breathing difficulty is important. If you can't complete a sentence, that's definitely a red flag. There are breathlessness checks. Do you have to breathe harder? Are you ill? Have things changed significantly in the last days? A red flag. And then consider sort of things to ask about: wheeze, leaning forward when you breathe. These are all red flags. And what I would say here, if you've got a patient who's very thirsty but hasn't been passing much urine, or their urine is very concentrated, I also feel, having read this data, that that's also a red flag. Now, Diarmuid Quinlan was sharing with me this new score, which is a way of scoring people's risk. It probably is a secondary care score, but can be useful in doing a full clinical assessment. The Roth score, as I mentioned earlier, this breathlessness that people get is very subtle, and it doesn't seem that the typical Roth score is a predictor for hypoxia in these patients, so can't as well be relied upon. So there you are with your diabetes workload. How might you prioritize it? You might look for patients that you know to have had poor control and deteriorating. You might look for patients with outstanding reviews, people at high CVD risk, people you know to have other comortalities, as I mentioned, asthma and so on, people who are on insulin, do they understand how to use it properly? And then newly diagnosed patients, they will benefit most from a legacy effect. So could you do a remote diabetes consultation? Yes, you could, but preparation is the key. You need to have their data in front of you, previous results. Are they self-monitoring? Have any flags to drug therapy been flagged up? And you might want to send out a questionnaire like this before you do a face-to-face consultation. And this is an algorithm that colleagues at PCDS have come up with. I don't expect you to read this, but I will send, along with these slides this morning, I will send you a paper on this if you're interested in remote consultations. So is COVID-19 a catalyst for positive change? Well, I think we will certainly understand and implement testing and tracing better. Governments will be better prepared. I'm really impressed the way the diabetes establishment has moved so quickly to interrogate the science and publish it, albeit its cohort studies or studies that are addressing populations. We will address our patients' metabolic health better. I wonder, will governments cooperate by taking on the giants in the food industry? We'll understand diabetes medication better during illness. I think we need to think about the emotional well-being of both our staff and patients. And is remote working of all types the future? I want to thank you, to stay home and stay safe. And at this stage,